Hello, this is your brain on drugs, and this is the punk rock psychiatrist. I'm doing this episode just as audio because I've recorded it twice with the video, and the entire thing hasn't worked. And so I'm getting kind of frustrated with my software, and I don't know what's going on. So I'm going to do this one just audio because I'm tired of going over this episode over and over. But today we're going to be talking about antidepressants and suicide risk. So let's go ahead and get started with that. So why are we talking about this? It's because there's a black box warning on these medications. All right. That's something that the FDA does. You know, they put these warnings and they put a little black box around them, and they're referred to kind of as black box warnings, but they're really called boxed warnings. And they're the highest kind of warning the FDA can give. And so the one that we're specifically talking about today is on suicide risk with antidepressants. So let's go ahead and just read off what it says, right? So it's patients under the age of 25 have increased suicidal thinking or behavior during the first 2 months of treatment. All right. And it's, pretty straightforward. And if I encourage you, I still have the slides available, so I encourage you to look at the slides so you can see my data. You can see where this information came from. If you look at patients under 18, there's like a little bit more than 2 times, about 2.2 odds ratio. That means that they're about 2.2 times more likely to have increased suicidal thinking or behavior if they're taking these meds compared to those that don't. And then we move into the 18 to 24 category. It's about 1.5 times more. And then once you get down to 25 to 30 years old, it's about 1.0. And then the risk actually goes down. 31 to 64, it's about 0.6. And then 0.4 for those over 64. Now, it sounds like, maybe these medications aren't the best medications. If you're looking at this data, it's like, so you actually have to be elderly before these medications even don't cause suicidal thoughts. Well, there's nuance to that. And that's what we're going to talk about in this episode. I want to go over the nuance. I want us to understand where this came from, what the warning's about, the kind of the history behind it, why they did it, but what were the unintended consequences that we're living with today, and which medications does this warning actually apply to? All right. So first, what I want to discuss is why this could be happening, right? Because these medications are supposed to make you feel better, right? They're supposed to make you not depressed. And now, people are having suicidal thoughts. Well, remember that it's only the first couple months of treatment that we're really concerned about this. And the thought behind that is, you remember how the side effects of these medications, people often get those immediately. The GI upset, headaches, dry mouth, whatever it is, they get those immediately, but they don't get the mood improvements until later. And so not all the symptoms of depression that people have respond in 1 to 2 months. Some of them actually may be responding a lot sooner. So a lot of these so-called neurovegetative effects, so these are like your fatigue, your motivation, that you don't feel like doing anything, those type of things may get better sooner. And so what you may be having is a person that was suicidal, but they just didn't have the energy or the will to act on it, and now they do. But their mood hasn't gotten better yet, and so they still want to die. All right. And it also could be, a lot of patients tell me that they had never even had these thoughts before. But we've all heard of the, quote unquote drunkicidal patients, right? And you get these patients that, tried to kill themselves or wanted to kill themselves while they were intoxicated. And then once they're not intoxicated anymore, they don't even remember this. And they can't even imagine how they could ever want to kill themselves. They're like, I've never thought about this. I want to, I'm not even depressed. Why would this happen? Right. And I think, maybe when your inhibitions are down, there might be some stuff under the surface that you're not quite aware of in your subconscious that, is a lot more able to come to the forefront. All right. And so that could be similar to what's happening here. So maybe they don't think that they ever had these thoughts, but maybe the thoughts were there. They were kind of where they couldn't access them, and the medication kind of unlocks the thoughts, and but that their mood hasn't gotten better yet. So this is why we tell patients, if you're going to hurt yourself, please go in and get evaluated, because you may need to be admitted to the hospital. But these medications do take a while to work. You may feel worse before you feel better, but and if you're feeling like something dangerous is going to happen, please tell somebody. Please come in. Um, please get that addressed. But that doesn't necessarily mean that we want to stop the medication, because it may be that just like the side effects tend to go away, this could also go away. And if we wait and if we're able to take the medications a little bit longer, we may see that benefit. Now, if they don't get better, I've had patients that have taken medications for, almost a year. And then they come to see me after they saw someone else. And I said, then they're still not doing well. And I'm like, man, you've been taking the same med at the same dose for like 9 months. And I'm like, well, they're like, oh, they said I should just keep taking it. Every time I went in, they said, just keep taking it. It's like, well, after a couple months, if you're not doing better, something needs to change. All right. So that's not to say, just shut up and take this and you'll feel better. No, it's let's keep an eye on this. Let's address this. If something's going on, let's talk about it. But let's try and keep it at least long enough so that we can see if it's going to have the effect that we want. Okay. And this was actually the intent that the FDA had when they put this warning on. They said, we're not saying don't take these medications. We're not saying that you shouldn't prescribe it, that you shouldn't give it to people. We're saying just be wary of this effect. And in fact, what they said was, and this is a fact that I only realized um, or that I only came to understand a couple months ago when I was really digging into this for this episode. And I was like, oh, wow, they actually didn't. The warning was see patients every week for 4 weeks, and then every other week for the next 4 weeks, and then at 12 weeks. That's the actual, like, if you actually, it's hard to find, because if you read the warning itself, that's not in there. But if you find where the warning came from and you find the intent, and it's super difficult to find, I don't like, their intent was, hey, just see the patient more often and monitor for these symptoms, but don't not treat them. And people didn't get this message. They didn't see it. You've got a lot of PCMs prescribing these meds that don't have time to find this stuff out. And I think a lot of people are just like, oh man, pediatricians and things who are treating a lot of these patients, like, oh man, this is a bad warning. I don't want, they're saying that they could kill themselves. I don't want to give them this medication. It seems unsafe. And so what happened was you just had a lot less people getting treated. And in the end, suicides went up. All right. So let's get more into that. Okay. So let's a little bit of backstory on what boxed warnings are, because this is our big boxed warning when we talk about psychiatric medications, and specifically when we're talking about antidepressants, because they all carry this. Boxed warnings is what the FDA refers to them as. Were introduced in 1979. They're the highest warning assigned by the FDA, and you can find them on over 500 medications. So they're very common. And I think uh, you might be surprised. Like, look up almost any med, and I think you'll be surprised that there might be a boxed warning there. Ibuprofen's got a couple, gastric ulcers, bleeding, cardiovascular events, birth control, cancer risk, cardiovascular events. A lot of medications that we think of as pretty run of the mill, everyday medications, many of which can be picked up over the counter, even not a prescription. They have these warnings. Now, over-the-counter meds don't carry the black box warning. So ibuprofen in the grocery store, no warning. Ibuprofen, exact same medication that I prescribe a patient, they pick up, warning. All right. So there's nuance to this. And I think people think about, oh, but it's a warning. It's bad. I need to like not do this. Well, the intention is not for you to not prescribe the medication. It's just for you to be aware of this thing and to take into consideration and see if, this is the best thing for the patient. But I think what most people do is they're like, oh, this is bad, I'm not doing it. All right. So specifically about these medications, in the SSRI, first SSRI in the United States it wasn't the first one ever, but it was the first one approved, was fluoxetine, 1990, or if actually like 1987, but in 1990 was the first published report of suicidal preoccupation with fluoxetine. And then 13 years later, in 2003, it was actually the UK's version of the FDA that issued a warning about paroxetine, another SSRI, in children under the age of 18, citing an increase in suicidality and also no benefit. And then later that year, they banned all antidepressants other than fluoxetine for children and adolescents. Banned. I don't know if that ban still stands. I'm not in the UK. In the US, they're not banned. There's only 2 SSRIs and one tricyclic that's approved for children, but they are all used off label. They're not banned. Um, but after this report came out from the UK, the FDA followed in 2004, and they put a warning on all antidepressants based on retrospective reports that showed this very slight increased risk of SI in children and adolescents. And then it was revised in 2007, and they knocked the age up to 24. So less under the age of 25 has the warning. So, and then any medication, this is a class effect, right? And I think when we think about these warnings, they're typically not given to an individual drug. They're given to a drug class. So they're given to antidepressants. Now, at the end, when I go through the meds, you're going to see that the nuance of antidepressants is not quite as straightforward as you might think it is in how this warning is applied to different medications. But they basically said all antidepressants, and they've included some meds that are technically not antidepressants, and they've excluded some that technically could be antidepressants, and that's what we're going to go into at the end. But they also said any new antidepressant that comes out, whether it's been shown to cause this or not, if you're an antidepressant and you come out, even if you have a completely different mechanism of action, you still get the warning. Where's the sense in that? Like, even if you have a completely different mechanism of action, and I think about esketamine Spravato, it's an NMDA receptor antagonist. It doesn't work anything like, it's not even working on the serotonin system. It has the warning just by virtue of the fact that it's used for depression. I don't understand the logic there. FDA, I think you had good intentions when you put this warning on there, and I think it's something that we need to discuss with our patients, but like, it seems kind of arbitrary and silly the way that this is being applied. And then on top of that, since that time, there's been more prospective data that has emerged that don't support this association, that actually show it going the opposite direction. And I'm going to go through that in detail. All right. So what there was a very small increased risk of SI and attempts, but no actual completed suicides in children and adolescents in the pediatric trials. So even though there's this risk that it could end in a completed suicide, there weren't any in the data. So we're warning, hey, this could happen, but it hasn't happened yet. But guess what? The fact that you're not prescribing it, now it's happening. All right. So since the warning was issued, there's actually been an increase in rate of suicides in severely depressed patients associated with a decrease in antidepressant prescriptions and a decrease in doctor visits. And so what I would say is inform them, monitor them for this, but this warning should not in any way prevent you from prescribing it, right? Now, it might be a reason to stop it on certain patients, but it shouldn't be a reason not to initiate the treatment. All right. So, one of the first papers that came out that showed that things weren't going the way the FDA had intended it is this paper that was published in the British Medical Journal 2014. The title is Changes in Antidepressant Use by Young People and Suicidal Behavior After FDA Warnings and Media Coverage, a quasi-experimental study. All right. And if you look at the slides, I've got 2 charts in here, and you can look up the paper and see the 2 charts. One shows the rate of antidepressant use going up, 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 up. 2004 hits, it goes down. And then you completed suicides. They're fairly level. This warning comes out. They go up, they go down, it goes up. It seems to have had not an impact on this, but we have some more data that shows that's because this is only one paper, but now this new paper that came out, and it's actually I just got it, just ran through my email, and I was planning to do this episode anyway. So, and it just got published in October 2024. So let's talk about that paper. So October 2024 review article from the journal Health Affairs, and what they did was they looked at the data from 11 different studies, and they took these 11 studies, they did a systematic review, and it showed that the FDA pediatric antidepressant advisory in 2003 and black box warning in 2005 were associated with the following unintended outcomes. Now, actually, all the outcomes were unintended. And on the title of the article, this is done by Sumerai et al. Intended and unintended outcomes after FDA pediatric antidepressant warnings, a systematic review. So you can look this up yourself. And I read it, and I actually didn't see any intended outcomes. All I saw were unintended outcomes. And let's mention what they are. So one, there were a reduction in the number of physician visits for depression. So less people getting care. Less people are seeing a doctor that could potentially prescribe. So they're not even going in. So like the patients are getting this message too of, oh my gosh, I don't want to even take this medication. The parents of these children, they're getting this message, oh, I don't even want my kids to see a doctor because these meds could cause this problem. All right. And so, and also, they might go into the doctor and the doctor's like, I'm not prescribing this. And so they don't have a follow-up, right? So you're also having less visits because, they're people that decided not to prescribe it. So they didn't follow patients up because they didn't give them anything, right? And then you also have a reduction in depression diagnoses. Now, part of this is probably because if you're not going in to see the doctor, you're not getting a diagnosis. So we're missing cases of people with depression, which is not good. And then the third point is that there's actually less therapy. So there was a reduction in psychotherapy visits. So that's not even necessarily related to taking medications, but people are just getting less treatment for depression as a whole after this warning came out. Fourth point, a reduction in antidepressant treatment and use. So this is the one I've highlighted. We're not prescribing the meds. People are not taking them. The rates are going down. And then the fifth unintended consequence is there's an increase in psychotropic drug poisonings, that's drug overdoses, and suicide deaths, right? So we actually have the unintended consequence where we had wanted to prevent suicides, we have more suicides. And I just want to, I wish I had my YouTube stuff working and the video, and those of you that wanted to experience the podcast that way would be able to do that, because I intended the podcast to be something where you could have many different ways that you got it. And I thought some of you might want to actually see me talk about this with the slides in front of you, because it might make it easier to understand. Although I think most people probably would want to listen on the podcast, but I do make all of my material. The show notes are available on my website, punkrockpsychiatrist.com. So I encourage you to go there, download them. You can follow along with the podcast. I apologize. I'm really upset. Like, first, the YouTube videos aren't recording the slides. It's just recording me. And now it's like, I've done this episode. This is the third time, and it's just failed to record it at all. So I'm very frustrated. But anyway, to talk about the study, when I'm looking at this chart, right? So I've got 3 charts that I got from that October 2024 study. And what you see on this first one, this is figure 1, that the rate, and we're starting in 1999 and going to 2009. And we've got this, like, when the advisory came out in 2004, 2005 in the middle, and you see a line, an uptrend increasing every year. You've got more. So not only are we having a reduction in physician visits and a reduction in depression diagnoses, there was actually a trend towards more and more and more of this every year. And then this warning came out, and there was a sharp drop and then a downtrend. And so there's then been a trending downward of less. So we were getting more and more and more care. Then we have a drop in care, and then we get less and less and less care every year. So it doesn't just have this effect of kind of causing a ripple around the time of the warning. It's actually, there's less and less and less visits every year since the warning. And so the next figure, it shows something similar where we're having a downtrending of suicides, a downtrending of drug overdoses, a down, and then another, I think kind of an unrelated line, but a downtrending of unintentional injuries, unintentional injury deaths. So this is, presumably they didn't want to hurt themselves, but they had an accident, a car accident or something like that ended in death. That line continues to go down because it's not related to these medications, right? So I think they were trying to compare it and say, oh, here's this other thing that maybe, these other kinds of deaths, they continue to downtrend. But psychotropic drug poisonings spikes up after the warning. Suicides goes up after the warning. So, and just every year, more and more and more and more. Figure 3. So in this one, you've got this uptrending line. We're going from 1996 to 2011 on this one. Uptrending, uptrending, uptrending. Percentage of antidepressant initiation, percent antidepressant use, prescription fills. So this is like, medications that patients are getting. And then sharp drop and then a downtrend. And then actually one of them seemed to, around 2008, start to bow back upwards again. So, not good. Not good. So I think next what we're going to discuss is which meds are affected. All right? Which meds? So I already mentioned it's antidepressants, but which ones? Well, it's all of them. But like I said, there's some nuance. So all MAOIs, all TCAs, all SSRIs, all SNRIs, all SARIs, and the NASSA, which is mirtazapine, and the SARIs, that's trazodone and nifazodone. So all of those, and this is the interesting point, almost all medications that are in that class, even if they're not approved for depression. So fluvoxamine, not approved for depression. We talked about that before, but it's an SSRI. It has the warning. I'm not sure why. It's not, technically it's not an antidepressant. And then milnacipran, only approved for fibromyalgia. It's an SNRI. It's on there. So it has the warning, even though it's not technically an antidepressant. However, Flexeril cyclobenzaprine, which is not a tricyclic antidepressant, but it is a tricyclic. We just can't say the antidepressant part because it doesn't have approval as an antidepressant. It doesn't have the warning, even though it has the same ring structure as the TCAs do. So kind of arbitrary. Okay. You've got a couple in here that are technically not antidepressants, but they're the same mechanism of action of other meds that are antidepressants. Then you've got your NDRIs. So some of these are, some of them aren't. Norepinephrine, dopamine reuptake inhibitors. So bupropion, which is brand names Wellbutrin for depression, Zyban for smoking cessation, both of those branded products have the warning. Zyban's not an antidepressant. It's a little bit different. It's 150. It's basically the same med, but it's a SR twice a day, but Wellbutrin has a SR variety as well. So both of those branded products of bupropion have the warning. However, methylphenidate, which is also an NDRI, and amphetamine, mixed amphetamine salts, Adderalls, Concertas, Ritalins, all those type of meds, they're NDRIs. They don't have the warning. All right, they're not antidepressants, but neither is milnacipran technically, but it has the warning. So I'm not real sure why that is. And then let's look at the 5-HT1A partial agonists. So that's gepirone and buspirone. Gepirone's an antidepressant, buspirone's an anxiolytic. Gepirone's got the warning, buspirone doesn't. Not really. Buspirone's not an antidepressant technically, but neither is Luvox. So, but it has the warning, Buspar doesn't. Not really sure why. But that it is what it is. Maybe it's because gepirone came out like last year, and so it was only buspirone, and they were like, well, that's not an antidepressant. That's not even a class of antidepressant. But then gepirone came out, as a same mechanism of action and got the approval for depression, and so it is an antidepressant. And so they're like, well, that's an antidepressant, so we have to count it. But we already didn't count buspirone, so we'll keep not counting it. So I'm trying to think through like why they pick one versus another. And then we've got some of the newer antidepressants. So Auvelity, which is dextromethorphan bupropion combo, and esketamine Spravato. Those are antidepressants. They carry the warning. And then we've got 3 antidepressant combination drugs. So they're a combination of an antidepressant with an either antipsychotic or benzodiazepine. So Symbyax, which is fluoxetine olanzapine, and Limbitrol, which is amitriptyline chlordiazepoxide, and then Triavil, which I wish I had mentioned, but I did not mention before when we went over TCAs because I'd never heard of it. It's not really used. It's a amitriptyline perfenazine combo. Not sure why. So I'd missed that one, and the only reason I learned about it was because I looked up the list of the medications that carry the black box warning, and it was on there, and I was like, "What's Triavil?" And so I looked it up. And so, I mean, it's kind of interesting. You think about the name Elavil, which is amitriptyline, and Trilofan, which is perfenazine, and they kind of smack those together and call it Triavil. And then the next ones, so brexanolone and zuranolone, those are the new medications that have come out for postpartum depression, which I would say they're antidepressants. I think they're even looking in. I mean, brexanolone is you have to give it IV in the hospital, but zuranolone's a pill. So I think there's even some look to see, might these be useful for unipolar depression, not just postpartum depression, but they don't carry the warning, as if to say postpartum depression is a completely different animal. And so I don't know that they don't have the warning for whatever reason. Next, meprodoline. We talked about that. It's a tetracyclic. So, I had said before that it was not approved for anything, and I actually was incorrect. What I found out was that it was FDA approved for depression. However, it's not been available since 2021. So no one is producing meprodoline anymore in the United States. And so you can't get it in the US, but it's on the list because it was FDA approved for depression at one point in time. I think it was like 79 or something like that. And then the next category is the antipsychotics. So there's 4 antipsychotics that are approved for unipolar depression. So unipolar depression is major depressive disorder, and bipolar depression is bipolar disorder. So quetiapine, Seroquel, aripiprazole, Abilify, brexpiprazole, Vraylar, and cariprazine. The name is escaping me at this moment, but actually, I think cariprazine might be Vraylar. I get those last two messed up, what their brand names are. But that's why we like to use drug names because I don't want to be a commercial for a drug company. And if you're a learner, you're not learning those brand names, but it is important to know what both of them are. So those 4 antipsychotics are approved for unipolar depression, so they carry the warning. And once again, we have other medications that work very similarly to them that are the same mechanisms of action, but they don't have any approval for depression, so they don't get the warning. Your guess is as good as mine. And then I mentioned before, we have unipolar depression, we have bipolar depression. But whenever we talk about what the FDA approved indications for certain medications that we use for bipolar disorder, there's actually 3. You've got bipolar depression. So that's, bipolar disorder is, sometimes you have mania or hypomania. Sometimes you have depression. Sometimes you have nothing, right? But you can go between those 2 poles. That's why I call it bipolar, right? So there are medications that are approved for bipolar depression. There are medications approved for bipolar mania, and there are medications that are approved for bipolar maintenance. And there's medications that have approval for more than one of those. All right. So there's actually 4 antipsychotics that are approved for bipolar depression: quetiapine, cariprazine, lurasidone, and lumateperone. Quetiapine and cariprazine are already on our list because they're approved for unipolar depression, but lurasidone and lumateperone were not. But now they get the box warning because, and lumateperone just got this approval. It was originally for schizophrenia, then they got approval for bipolar depression. So then they get slapped with this label. And the traditional mood stabilizers, lithium, valproic acid, and carbamazepine, actually, I mean, they actually don't have approval for bipolar depression. They're only approved for bipolar mania. And I think they may have bipolar maintenance. I can't remember which one does or doesn't. But because they don't have the bipolar depression, that's why they don't have this black box warning. And then one last very obscure uh, add-on is atomoxetine, which is a norepinephrine reuptake inhibitor. It's the only one approved in the United States. Reboxetine is another one. I think it's available in some other countries. But atomoxetine, Strattera, it's a medication used for ADHD. And remember, methylphenidate and mixed amphetamine salts that do not get this black box warning, but for some reason, atomoxetine has been gifted with the black box warning. So maybe there's some data that said there's some data that said that ADHD medications could cause this, but even even so, only atomoxetine was given the warning. So I hope that you really kind of learned a lot about like what causes where did this black box warning come from, why why should you be concerned about it, when should you not be concerned about it. And I think the bottom line is you should know that this is a potential effect that patients get. And even though the warning is only under 25, I see this happen to patients over 25. So you can't just say that it's not going to happen because you're not in this age group, which is another arbitrary thing, right? And this is something that I talk a lot about when I talk about medications. A study could come out that says that something doesn't work, but that means it just doesn't work on average. There could be a handful of patients that it works really well for. There could be a handful of patients that almost die from the med, and they just all average out to nothing. Or you could have something that averages out to being helpful, but it really doesn't help other people. Or something could average out to actually not working, but there's still some people that works for, right? And that's the thing. We draw these lines, but they're based on statistics, right? They're based off of these statistical analyses, and not all patients are the same. And so even though this warning is for a certain age group, I warn all my patients about it. I talk about it with all my patients, and I don't withhold any kind of treatment because of this warning. I still see them, I still prescribe meds, I tell them, what to expect, and I follow them up. And that was really, I mean, but I still don't do what the FDA says. Being in the, treating being a provider in the military, I would say over half of my patients were under the age of 25, so that they fell into the category of this warning. Um, so it's something that you have to discuss with them, and I did see it, but I saw it in patients over 25 too, and that's why you got to discuss it, but at the same time, like, you don't withhold something that could potentially be beneficial because of a warning. You have to, and you don't have time for this. You don't have time to find out about it. And that's why I hope, you found my podcast, and I hope that you've found me to be a trustworthy source, that you found that, you can search me online. You're not going to find much. If you dig really hard, you'll find my website, you'll find my podcast, and maybe if you search on Google Scholar, you'll find the 4 papers that I published. But that's it. I'm not out there. I'm not giving talks for drug companies. I'm not. I'm not selling supplements. I'm not, being paid. I'm not putting ads in my podcast. And, this may be a reason why a lot of people don't find me, because, they're finding the people out there that are taking money from the drug companies, because these people are known, and they have a network of people, right? I tend not to trust this, because even if I think they have good intentions, you they did a study on this. Doctors who took lunches from drug companies said that they weren't influenced by it. But when they looked at doctors that took these benefits versus the ones that didn't, They prescribed more of the meds that these people were advertising to them than the other people did. And that's just the truth. And that's not to say that there aren't doctors out there that are able to like fight through that bias, but it's something that they're not doing on purpose. They don't think they're doing it, but the fact that you're exposed to it, the fact that you're taking this money or gift or whatever it is, it plants the seed in your mind. Okay. And so I'm hoping that you will tell everyone about my podcast, because I'm doing the research that you don't have time to do. I'm reading the articles. I'm going through the data. I'm making the decisions, and I'm not doing it for money. I'm not doing it for these. I'm not trying to get anything out of this. I enjoy teaching. I enjoy giving this information out. I enjoy sharing this, and so hopefully you can come and you can look at the list of episodes that I have on offer, and you can see, oh my gosh, I really want to learn about that. And I really trust him. And, I'm going to sit down for 30 minutes and listen to it. Maybe I listen to it at double speed because he blathers on and on about a bunch of stuff I don't care about. But hopefully you've got the information on that black box warning, and that your practice could potentially change for the better. And hopefully the FDA will look at this data we have from this October 2024 report and maybe update it, because we don't want less visits and less prescriptions and more suicides, but that's what's happening. All right. So follow, tell your friends, and I will see you on the next episode.